Hello and good evening, everyone. Welcome to our 68th Blue Health Virtual Seminar. Blue Health Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Health Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer, aiming to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And I'm your host, Dr. Rihinot Adela, a general physician and first aid trainer from Blue Health Ethiopia. Today, it's an honor to have Dr. Mamude Dinkiye here with us. Doctor will be presenting on the blood and blood components transfusion on today's session. So for those of you who don't know Dr. Mamude Dinkiye is an assistant professor of pediatric hematology and oncology at St. Paul Hospital Millennium Medical College. So, Doctor, the stage is all yours. You can start.
Thank you so much, Dr. Iheno. Using this opportunity, I would like to thank you, your firm, Ethiopian Society of Hematology Oncology, for giving me this chance to talk about blood and the blood component transfusion in Ethiopia. These are the outline of my presentation. We will talk about the history of blood and the blood component transfusion briefly. Then we will go to introduction, procedures in supply chain, blood components, medical indications of transfusion, adverse effects of transfusion, and last we'll talk about the management of adverse effects. The objective of today's session is to describe the different types of blood components, to list indications and the contraindications of transfusion, to describe procedures in supply chain management, to apply appropriate knowledge and the skills of blood component administration, monitoring and reporting, to identify the adverse effect of transfusion, to manage the adverse effect of transfusion, and lastly, in our respective health facilities, we are expected to identify practice gap as compared to the standard we are going to talk about. Briefly, history. Blood transfusion is one of the oldest practice in medicine. It is almost 400 years ago when William Harvey discovered circulation of blood in human body. Then after that, in 1665, the first successful transfusion occurred in England using dogs. In 1818, James Blundell performed the first successful transfusion of human blood to the patient for the treatment of postpartum hemorrhage. After many years, almost closer to 300 years, Karl Landsteiner discovered the first three human blood groups, ABO. In 1907, the first blood typing and the cross-matching started. In 1914, anticoagulants developed for blood preservation. RF system was developed in 1939. Albumin, gamma globulin, and the fibrinogen started to be used in 1940. In 1947, you know that history, the famous syphilis test started on donated blood. In 1971, hepatitis B surface antigen screening started, and in 1985, with pandemic of HIV screening started on blood donation. Coming to introduction, blood transfusion is the process of transferring blood components into one's circulation usually intravenous. The widely used route is intravenous. Early transfusion used whole blood. Some decades ago, whole blood was being used, but the modern practice commonly uses components of blood by the principle of 1, 2, 3. That means one donor can save the life of 3 patients because from one donor's blood we can extract packed RBC, we can extract fresh frozen plasma as well as the platelets. That is the reason why we are saving one donor can save the life of 3 individuals. It is a widely performed procedure in medical practice. Coming to any secondary or tertiary hospital, the most widely performed procedure is blood transfusion. Good to know the keynotes which were listed by WHO, World Health Organization. Number 1 is transfusion should be undertaken only to treat conditions that would lead to significant morbidity or mortality, and no alternative means to manage or prevent it. That means a widely used approach is the conservative approach of transfusion. You will decide on transfusion if you don't have alternative way to alleviate the symptoms or the signs of the condition of the patient. Number 2 is more than 30 minutes should not elapse once the blood is at the patient site. Now you can reflect back to the practice. More than 30 minutes should not elapse once the blood is at the patient site. Blood should not be sent back to the bank or the storage place once it was at the patient site. It is a good practice taking peripheral smear of the patient before any transfusion. The other one is blood and the blood component should not be used for resuscitation. For a patient in shock, especially due to bleeding or due to fluid loss, the patient should be resuscitated with fluid, and after that, the decision for transfusion should be determined, not blood for resuscitation of the patient. Hemoglobin value, though it is important, it should not be the sole deciding factor to decide on transfusion. It should be combined with the overall clinical condition of the patient. The decision to transfusion should be supported by the clinical signs and the symptoms, or with intention to prevent significant morbidity or mortality if we don't manage that anemia. It is always important to be aware of the risk of transfusion-transmitted infection, which we can minimize, but which we really cannot eliminate the risk. Transfusion should be prescribed only when the benefits are likely to outweigh the risk. This means there is always a risk associated with transfusion, though the degree can vary from place to place. It's important to clearly record the reasons for ordering transfusion. That means the clinical diagnosis and the clinical condition of the patient should be clearly documented. Trained staff should monitor transfusion and respond immediately there are any signs of adverse effect. It is very important to know transfusion should be monitored by trained staff. As much as possible, transfusion should take place during the working hour when we get adequate number of trained staff to monitor the patient on transfusion. We said there is no 100% safe blood or blood component, but what can be considered safe blood? Number 1 is if it is donated by carefully selected, healthy, regular donors. If it is free from infections that could be harmful to the recipient. If it is processed by reliable method of testing, component production, storage, and transportation. If it is only done upon the medical need of the patient, not for other reason, only for medical purpose. World Health Organization Blood Safety Initiative states there should be established well-organized blood transfusion services. In our case, the blood bank in the national level as well as regional as well as some facilities. Collection of blood only from voluntary, non-remunerated donor from low-risk population. We need to carefully select blood donors. Screening of all donated blood for common and endemic infections like HIV, hepatitis B, hepatitis C, syphilis, and malaria in our case. Good laboratory practice should be in place to properly conduct the screening and the testing as well as cross-matching procedures. It is very important to reduce unnecessary transfusion. Transfusion should be done only for medical indication. That should be clearly stated. Blood donation, it could be autologous or allogenic. Autologous means from self. For example, a person can donate blood for future use if, for example, elective surgery is planned. This is applicable for a certain group of religion like Jehovah's Witness, where allogenic transfusion is not accepted by the followers. In that case, autologous transfusion can be planned. Allogenic is when somebody is receiving the blood which is donated by another person. The blood can be donated from voluntary donors or from recruited donors or for replacement for family members. We usually encourage blood donors to be from voluntary, non-remunerated, and regular donors. Who are eligible donors? The eligible donors should be in good physical as well as mental health. The age should be between 18 to 60 years. The hemoglobin value for males 12.5, for females 11.5. The minimum weight should be 45 kilograms. Normal blood pressure without treatment, normal pulse rate and the temperature, and for those who are regular donors, the interval should be minimum of 3 to 4 months. WHO recommendation or estimate of blood requirement for a nation or a health facility. The estimate is general estimate by WHO, World Health Organization. 1% of the general population needs 1 bag of blood at a certain point in time per year. Coming to Ethiopian population of 120 million, that means 1% of the population need 1 bag of blood per year. In that case, in Ethiopia, 1.2 million bags of blood are needed or should be harvested every year. I wish people from the blood bank are participating. There is a critical gap in this one. From my information, annually in Ethiopia, the amount of blood which is harvested is not more than 300,000. Instead, the gap is very huge. That means only what is required is a very small amount of what is required is harvested. Of this, at least 20% has to be blood components. From this 1%, 20% should be used for component preparation. Coming to health facilities, this is still WHO estimate. 6.7% of hospital beds need 1 bag of blood per year. For example, in a health facility or in a certain tertiary hospital with a bed capacity of 1,000, 6.7% of beds needs 1 bag of blood every year. 6.7% per year. 1,000 times 360 times 6.7. Imagine the amount of blood which is needed in that particular health facility. Coming to compatibility of ABO and RH system, what is very important is O negative is universal donor. The vertical, the column, the initial column, O negative is a universal donor. The first row, AB positive is a universal recipient. This is from urology. When we see blood, you can see the first tube is whole blood. After the first centrifuge, you can see the plasma on the top, the buffy coat in the middle, and the packed red cells at the bottom. This bag is containing plasma. Usually, our patients are calling it yellow blood. When we come to the process, whole blood is harvested from the donor. The first centrifuge will separate platelet-rich plasma from red cell concentrate. If we further centrifuge platelet-rich plasma, we can separate so this is where we are. Fresh frozen plasma can be used as fresh frozen plasma, and it can be stored in deep freeze, or it can be used for components preparation, or it can be used to prepare cryoprecipitate. Cryoprecipitate, as you know, it is rich in factor 8, volume 1 factor, factor 13, and fibrinogen. This is another algorithm. Whole blood, you will get blood components. The blood component will be processed like the previous procedures. And from plasma, you will get blood derivatives or blood products, which can include factor 8, 9, albumin, immunoglobulin, prothrombin complex, and others. Apheresis, it is very important to know a procedure called apheresis. In this case, the donor is connected to blood cell separator, and the whole blood is collected in an anticoagulant solution, and the required component is removed, and the remaining blood will be returned to the donor. It is using a machine. It is expensive. It is not available everywhere. In Ethiopia, it is available in the blood bank, but the functionality is on and off. This is apheresis machine. You see the machine. You see the donor. The donor is connected. The blood which was drawn from the donor will go to the machine. It will be processed. The component which is required will be removed here, and the remaining blood will be returned back to the donor. This process will need some hours. The donor should be patient and they should wait in this area for some hours. And in our case, this is a big problem. Apheresis application in addition to blood donation. There are medical indications for apheresis, as you know, for therapeutic purpose like for thrombocytosis. Platelet apheresis can be done for medical indication. For hyperleukocytosis, leukapheresis can be done. For certain immunologic conditions like autoimmune hemolytic anemia, especially the cold type, Guillain-Barré, SLE, and other immunologic conditions, we can use plasmapheresis. Erythropheresis can be used for erythropoiesis, or sometimes it can be used for iron overload. Erythropheresis. It's good to know that this is different from exchange transfusion, which we usually practice in neonatal ward. Apheresis is different from exchange transfusion. Frequency of blood group in Ethiopia. Majority of blood group are Rh positive, and O and A blood group are the common types of blood group. This may have some question because the test type which we are using to screen for Rh status may not be as sensitive as the test type which is used somewhere else. So this is just for your information. Otherwise, globally, 15% of the population is said to be Rh negative. In Ethiopia, it is around 9%, which could be underestimation. Good to know the other blood groups, in addition to the major one, AB and Rh. Very important, Kell, Lewis, Duffy, Kids, P-type antigen. There are different types of antigen in addition to the major ones. Time limits for transfusion. The blood component, the starting time, and the completion time. For whole blood and the packed red cells, as we said already, the blood transfusion should start within 30 minutes of removing the pack from refrigerator and should be completed within 4 hours. In less hours can be used in high ambient temperature like hot places or hot environments. Platelet concentrates, as soon as it is removed from the lab and the patient site, should be collected immediately and should be finished within 20 minutes. There is no risk of overload in platelet transfusion. In FFP, fresh frozen plasma, should be collected within 30 minutes and should be finished within 20 to 30 minutes. This is to save the labile coagulation factors. Whole blood is around 450 ml of donor blood plus anticoagulant. The hematocrit concentration of whole blood is usually corresponding to the donor hematocrit. It can range from 35 to 45. Basically, there is no functionally effective platelet unless it is fresh, unless it is less than 24 hours or maximum less than 72 hours. There is no labile coagulation factors. You know, some coagulation factors are labile to the environmental temperature. Storage temperature is 2 to 8 degrees Celsius, and shelf life is usually 35 days using the conventional anticoagulant CPDA. Indication for whole blood, as we said already, whole blood transfusion was the old practice, but still there are some indications for whole blood transfusion, like in acute massive blood loss. Acute massive blood loss is when the blood loss has led to shock in a patient, like accidents, road traffic accidents, or obstetric conditions. In this case, when the patient loses more than 30% of his own blood, we call it acute massive blood loss. In this case, we need to replace both the blood cells and the plasma. In this case, whole blood transfusion is indicated. Whole blood transfusion is also indicated in neonatal ward during exchange transfusion. In fact, when the packed red cells is not available, it can be used to keep the life going until packed red blood cell is available. Risk of volume overload in a patient with chronic anemia, in a patient with malnutrition, in a patient with compromised cardiac function should be properly followed. And ABO identical and cross-matched compatible blood should be used for transfusion. Now coming to red cell concentrate, it is extracted from the whole blood after the first centrifuge. It is usually, the volume is 250 ml and the hematocrit is ranging from 55 to 75. Expected hemoglobin rise in ideal situation. 4 ml of red cell concentrate per kilogram will raise hemoglobin by 1 gram per dl. The volume, as it is said, 250, storage temperature 2 to 8 degrees, shelf life is similar to the whole blood, 35 days. Indications for red cell concentrate transfusion: symptomatic anemia. In acute massive blood loss, along with fluid, it can be used. ABO and cross-matched compatible blood should be used, and the infusion should be complete within 4 hours or less in high environmental temperature. Coming to the old practice of blood warming. Blood warming is not routinely indicated unless there is a need for massive blood transfusion. In neonatal ward, we need to warm blood, or in certain autoimmune hemolytic conditions like the cold type, warming blood or warming the room or warming the patient can be used. Special treatments of blood. Good to know reduction, which many countries are doing. Good to know also irradiation in a certain immunocompromised recipient. Irradiation is very important. Washing of blood is also very important because it will reduce the risk of allergic reactions. Good to know a special group of patients when we are doing transfusion, like neonates and unconscious, or patient in operation theater, anesthetized. Good to know that adverse transfusion reactions can be masked because the patient cannot report. So good to be vigilant when we are transfusing such kind of patient. Malnourished, chronic anemia cases, and the cardiac cases. The cardiac reserve in this group of patients is limited, so we have to cautiously transfuse slowly with frequent monitoring, and sometimes we need to give diuretics before starting transfusion. In sometimes autoimmune hemolytic conditions, practically, it is very difficult to get cross-matched compatible blood because still the blood will agglutinate on the slide. So this information is very important. As much as possible, we need to avoid transfusion, but if transfusion is a must and necessary, we have to medicate the patient with paracetamol, hydrocortisone, and be monitoring the patient very closely. Platelet concentrates. Platelet can be harvested in 2 ways. One is pooled platelet from different donors, from different blood bank, and the other one is from platelet apheresis, from one donor using apheresis machine. This one is better because we are not exposing a patient to various type of platelet antigen which is coming from different donors. The storage temperature for platelet is the room temperature. 22, 40 degree, 24 degrees, and it can be stored up to 5 days. This is in line with the half-life of platelets. The indications are thrombocytopenia due to decreased production of other causes, or due to hereditary platelet function defects. Platelet transfusion is indicated. Platelet concentrate, ABO compatible is preferable if possible, but still, if we don't have ABO compatible platelet, we can transfuse incompatible platelet, especially if the contamination with other cells is very minimal and the patient should be monitored closely for reaction. Contraindication for transfusion of platelets, as usual, ITP, unless the patient is critically and significantly bleeding or the patient is not scheduled for surgery. Thrombotic thrombocytopenic purpura, it is just like adding a fuel on a fire when you give platelet in such patient. DIC, there is no use. Thrombocytopenia associated with sepsis, or in case of hypersplenism, this is still wasting platelet because the transfused platelet will go to those sites and get sequestered. The rule of thumb, ideal, this is not practical. Ideally, 1 bag of platelet per kilogram body weight will increase by 10,000 per meter square body surface area. Fresh frozen plasma. It is extracted from the whole blood after the first and second centrifuge. The volume is 200 to 250. It contains majority of clotting factors with a ratio of 1 unit of clotting factor per ml of plasma. It also contains albumin and immunoglobulin. It is usually stored at minus 18 degree and it can be stored for up to 1 year. There are many indications for plasma transfusion, like for a condition whereby we need replacement of multiple coagulation factors, like in case of liver failure, in case of anticoagulant overload with warfarin, in case of depletion of coagulation factor in patients receiving large volume of transfusion, in case of DIC, in case of inherited bleeding disorders, when individual concentrates are not available, fresh frozen plasma can be used to alleviate the symptoms. As we said, fresh frozen plasma is stored at minus 18 degree, so it can be transfused after thawing in warm water. 30 to 37 degree. We have to bring it to the closer to the body temperature. And it should be transfused as soon as thawing, and it must not be refrozen once it was thawed. The compatibility is the opposite of red cells. Opposite. If compatibility has to be checked, it is opposite. Or is a universal donor because it does not contain A antibody as well as B body. Crispet is after swallowing fresh frozen adequate amount of factor 8, bone 1, 5 nanogen, and factor 13. It is indicated when individual factors are not available for hemophilia A, for warm bilirubin diesel, factor 13 deficiency, or fibrinogen deficiencies. 1 pack per 10 kilogram body weight, 12 hours should be administered until the clinical condition of the patient improves. Blood products, factor concentrate, we have many factors, factor 8, factor 9, factor 7, bone membrane factor. This is processed using lyophilization, and it can be stored for several. These are individual factors. This is factor 9, and this is bone membrane. We have factor 8 and checklist before blood collection. Prescription should be complete and a valid informed consent by the patient or the attendance has to be secured. Patient has to be assessed. IV line should be secured and should be patent and should be reliable. Any pre-medication prescribed for the patient has to be administered prior to transfusion. Trained and competent staff should be available throughout the transfusion. And patient is available for the transfusion time. No interruption, no going to toilet, no going to procedure, no going for investigation. Once transfusion is started, the patient has to be on the bed. Should be properly planned. Those who can be educated, they should be educated to self-report any reaction because they can report fever, they can report chills, rashes, riders, pain, chest pain, flank pain, they can report. The general condition of the patient should be closely monitored, especially in the first 15 minutes. Vital signs every 1 hour, that is what we recommend. Skin condition should be vigilantly observed for any rash. Coming to adverse, basically immunologic adverse effects or infection-related adverse effects. And immunological adverse effects are very common, and there are many. Acute hemolytic reaction, delayed hemolytic reaction, anaphylactic reaction, acute lung injury, transverse disease, GVHD. When we see them one by one, acute hemolytic reaction, it usually happens within 24 hours. Or during administration of blood. It is usually due to administration of incomplete clinical errors. That means wrong patient to the right patient, or right blood to the wrong patient during the process of right blood, wrong patient, or wrong blood to the right patient. The manifestations are fever, chills, chest pain, back pain, worsening of anemia, hypotension, flank pain, back pain, and in this case we have to immediately stop transfusion and we have to investigate. And the patient should be given more food. We have to keep our eyes on urine color so that the patient will not develop renal failure due to hemolysis. Delayed hemolysis is due to low level of antibodies in the patient's blood. Mostly it is due to kid antigen. It is usually mild, and most of the cases it is uh, not reported, the patient may not report, and certain patients are at risk of delayed hemolytic reaction, like patients who are given blood component in the past, or reproductive age group mothers who are giving childbirth or who has experienced abortion are at risk of delayed hemolytic reaction, because febrile hemolytic reaction, it is due to release of inflammatory chemicals from the donor's WBC or attack of donor WBC, but in general it is cytokines mediated. One method of preventing this type of reaction is by reco-reduction. Reco-reduction will not help. Pre-storage reco-reduction will. We need to exclude hemolytic reaction before, in this case, still we give antipyretics. We complete transfusion slowly, and we encourage the patient to take fluids. Mediated, either in donor or recipient, and high fever. In this case, transfusion rate, and we can compress. We have to immediately stop transfusion. We have to give vasopressors, and we have to give corticosteroids. Transfusion-related acute lung injury, it happens within 6 hours of transfusion or during transfusion. It is antibody mediated. Antibody is directed to the neutrophil. This antibody neutrophil interaction will lead to capillary system in the lungs in the patient present with fever, hypotension, shortness of breath, and tachycardia. In this case, we have to rule out fluid overload, especially in at-risk recipients. And it will show usually bilateral infiltrates. We have to administer oxygen. These are hypos, and it is fatal. Usually the fatality rate entirely is very high. Transfusion-associated circulatory overload, it is usually happening at risk patients, which I have already said. The most important clinical finding which will help us to differentiate therapy from TACO is raised JVP. JVP is raised in TACO, transfusion-associated circulatory overload. It is not raised intrally. If we have a facility to determine blood natriuretic peptide, it is elevated in transfusion-associated circulatory overload. Intrally, it is normal. There is evidence of left-sided heart failure in this case. There is fluid balance, and the radiologic evidence of pulmonary edema is there, and the diuretics are useful in such cases. Graft versus host disease. It is common in immunodeficient patients. The pathogenesis is when the patient fails to remove the donor T lymphocyte because they are immunodeficient, and there is some degree of T lymphocyte engraftment in the recipient. And during this process, there is reaction, antigen-antibody reaction, and it usually happens after 1 week of transfusion. The manifestations are fever, rash, diarrhea, and there is high mortality associated with GVHD. Immunosuppressive drugs can be used like steroid or treatment. And to prevent GVHD, irradiation will kill T lymphocytes. Infectious complications, acute infection due to contamination. Usually contamination are due to cold growing microorganisms. The best example is Yersinia pestis and Staph epidermidis. These are cold growing microorganisms. There is a chance that it can be contaminated. But the most important infectious complication is chronic blood-borne infection with a type of disease which we have already mentioned, HIV, hepatitis, syphilis, malaria, and others blood-borne infections. Coming to immediate management of life-threatening reactions, the first action should be stopping transfusion. But we have to keep the IV line open. Infuse normal saline to maintain the blood pressure normal. If there is airway compromise, we have to give oxygen. We need to give adrenaline, steroids. If there is evidence of airway obstruction, especially the upper airway, bronchodilators can help. If there is evidence of renal overload, Lasix, diuretics, we need to monitor urine output as well as urine color. And what is very important is we have to return back the giving set, the blood back, and we have to take a sample from blood of the patient, and we have to notify the bank for investigation about the reaction. If bacteremia is suspected, we need to start broad-spectrum antibiotics, and we have to send gram stain and the culture to identify the etiology. Coming to iron overload usually happen in those patients who are getting blood frequently. And at-risk patients are like thalassemias, sickle cell anemias, or aplastic anemia cases who are getting blood regularly. What is very important is 1 ml of packed red cells will add 1 milligram of iron to the recipient. 1 ml of whole blood will add 0.5 milligram of iron to the recipient. Transfusion of 250 ml of packed RBC twice monthly will add 6,000 milligram of iron to a recipient. Imagine, this is overload. There are certain organs which are at risk, like liver, heart, pancreas, gonads, the nervous system, and the skin. And these organs are affected by the mechanism of free radical formation because iron will form free radical and damage this liver, heart, and pancreas. To investigate patients who are receiving blood frequently, what we can do in our setup is serum ferritin. If we have facility, we can do iron binding capacity, and RBC indices. But the most important and sensitive test is liver MRI. If possible, liver biopsy is the most important and more sensitive than serum studies. The management, in our case, iron absorption from the GI is controlled in human being. When there is adequate iron in the body, the iron absorption from the GI reduces. This is a controlled mechanism for iron absorption. This is natural, which is protecting our body from excess iron. But it is very important in such case to reduce food which are containing adequate amount of iron and vitamin C, because iron and the vitamin C will increase iron absorption in the GI. So we'll advise the patient to take less iron and vitamin C rich food. In obese settings, there is chelating drugs which can be used parenterally or orally, like deferoxamine or deferoproxazole. Exchange transfusion or erythrophoresis can be used in certain conditions of iron overload, if especially a patient can be a central line can be inserted. Recording of transfusion is very important. Recording is very important. I hope you will understand this as compared to our practice. Consent is very important. There is no transfusion without consent, either a patient or relative. Indications has to be clearly stated. The prescribing physician has to put signature. Pre-transfusion checks. The patient identity is very important, as we said, especially hemolytic transfusion reaction is due to clerical error. So the patient identity, the RBC pack, FFP pack, platelet pack should be cross-checked with the patient. Signature of a person performing the check. Ideally, two people should check. Two people should check the bag against the patient identity. Type and the volume of the component, donation number, blood group, time at which transfusion commenced, signature of a person who is administering, any transfusion reaction, if there is, time transfusion has ended, has to be documented, and the transfusion slip has to be returned back with reaction. The blood bag should be notified about the outcome of transfusion. Thank you so much. These are my references.
Okay, thank you very much, Doctor, for the nice
welcome. Thank you.
presentation. So it's time for the question and answer section. So participants, if you have any questions regarding the topic, you can write down the questions in the Q&A section. So in the Q&A section, there is one question by Zariyun Nangasha. He said, is there a maximum limit to be a donor?
Thank you so much. We have tried to say somebody can donate several times, but the interval between donations, minimum 3 to 4 months, as long as that person is healthy and donate as many times as possible. I don't. Another question is there any blood which is free from infection? Basically, for example, FFP is stored in refrigerator for up to 1 year. In such a case, we can say, unless there is contamination during supply chain, FFP we can say relatively safe. When we come to the platelets which are stored at room temperature, they can be at high risk of contamination, and FFP can be, we can say, relatively safe because they are stored at deep freeze for many months. But in general, there is no 100% free of contamination. Coming to autoimmune hemolytic anemia, as we said, getting cross-match blood is not easy in such patients. So if the patient can be managed by alternative way, we have to use alternative way of managing such patient. But if transfusion is mandatory, we have to pre-medicate properly and we have to use the least incompatible blood for transfusion, and we have to use a small volume and slowly.
If the patient was diagnosed with malaria, would transfusing the patient benefit for this patient? Does transfusing this patient cannot benefit for the patient? For a patient diagnosed with malaria, can transfusing the patient benefit him or her?
Thank you so much. Very practical question. Malaria patient, the cause of anemia, if it is due to malaria, unless the patient is symptomatic, we treat the malaria, but if the patient is symptomatic and the patient is having malaria, we can treat both at a time because we cannot wait for a symptom. We may lose the patient. So we treat the malaria at the same time if transfusion is required before completion of anti-malaria or before of malaria parasite. Still, we have to save the life of in transfusion is we need to know the cause of anemia. Why this patient develop anemia? We need to treat the cause unless the patient is symptomatic and they need urgent transfusion.
Okay. Thank you, doctor. So Zarion asked, is there any contraindication to donate blood for a person with a tattoo?
Tattoo?
Yeah.
Not really. The contraindications are those eligible donors. We have already listed the eligible donors based on the weight, based on the age, based on the vital signs, the clinical, mental health, physical health, other than those. And as long as they are regular donors and the patient, the donors are screened and we know their status, there is no contraindication. Like a patient has underlying medical condition, patient with sickle cell thalassemia, which in this case they have already abnormal cells. We cannot use their blood for donation as long as their cells are abnormal. Hemoglobinopathies, enzyme deficiencies, inherited disorders, they cannot be used for blood donation.
Okay, thank you very much, Doc. The other is, can we transfuse blood drawn from therapeutic phlebotomy?
That one is challenging the phlebotomy. What was the reason for phlebotomy? Is it due to pulmonary or something else? Basically, that is not used. Or is due to polycythemia blood? Definitely, because that blood cells are abnormal cells. So I don't advise.
Okay.
The blood which was drawn from a patient, these are patients, these are not the donors. These are blood drawn from a patient for transfusion. I don't advise. Rather, such blood can be repurposed for laboratory use, like for culture media, you can use them for culture media in the lab, like blood agar. That is my advice.
Okay, doctor. Thank you. So the next question is by Malcolm. So how do we calculate the transfusion rate or drop rate when giving whole blood?
It depends on the clinical condition of the patient and the ambient temperature, environmental temperature. If you know the hemoglobin of the patient and you desire to, that calculation is not usually practiced. The desired hemoglobin minus the current hemoglobin times weight of the patient times 3 can give you the rough estimate of the amount or the volume of blood, but that is not very important. What is very important is transfusion relieve the symptom of the patient or improve the clinical condition of the patient. There is always one principle: treat the patient, not the lab result. Whether you are targeting hemoglobin of this or that does not matter to me. What matters to me is the elevation of the clinical condition of the patient. Whether the patient will need 1 bag or 2 bag, I will gauge based on the change in the clinical condition of the patient, not the lab, the desired hemoglobin. That is my advice.
So by how much does a unit of platelet increase the platelet number in pediatrics and adults? Is the question.
That is ideal. Still, I said it ideal. It is a rule of thumb is saying 1 bag of platelets from full donor, 1 bag. If you give it for 10 kilograms, it will increase by 10,000. But that is not happening practically. That does not happen. Because there are a lot of conditions which can affect this. Number one, how much platelet is in the bag is number one question. It is reflecting back to the amount of platelet in the donor. That is number one. The amount of platelet in the bag. Very important. How is the supply chain? How is the platelet stored, transported, and administered? Agitations, techniques, a lot of techniques involved. And the clinical condition of the patient. How is the underlying clinical condition of the patient? Does the patient have sepsis? In that case, you don't expect significant increase. Does the patient have hypersplenism? You don't expect. ITPs, you don't expect. But in a normal condition, it is said 1 bag per kilogram by 10,000. But that is just for the knowledge. Thank you.
Okay. So how much unit of whole blood is needed to prepare a unit of platelet?
Yes, from one blood bag. From one blood bag, you can extract 1 unit of around 60 ml from one blood bag. That is why we said
All right.
the blood bag we have, which is containing around 60 ml, was removed from 1 bag of blood. Yes.
All right, doc. So the other question is, when do we say blood transfusion is massive?
We call blood transfusion is massive. If you give the equivalent volume of the patient's blood, you see, how much is the volume of blood in that patient. That will depend on the age and the weight as well as the sex of the patient. For example, if 10 kilogram weighing child, if the estimated amount of blood that is having is 70 ml or 80 ml per kg, 10 kilogram times 70 is 700 ml. If for that patient you give equivalent amount of the volume of the blood, that is called massive, over a few hours. Did I answer?
Yes. Oh, okay. The other question is by Tamrat, and he said, what is the option of blood warming in Ethiopia?
Blood warming, we don't advise blood warming for normal transfusion. Blood warming is indicated only in neonatal ward. When you do exchange transfusion, you do blood warming in a warm water bath. Number one, you do blood warming in case of massive transfusion. You have to warm. You also advise blood warming in a patient with autoimmune hemolytic conditions like the cold type. Blood warming is indicated. Even in those cases, instead of blood warming, room warming or patient warming is very important because it is very difficult for us to control the temperature after warming. It's difficult, practically difficult to know the temperature of that warm water and after warming the temperature of that warm blood. There is a chance we can lose some of the red cells through the warming process. Traditionally, we see patients putting or attendants putting under their armpit. Still, that one is not effective way. So blood warming in general it is not indicated. It is only indicated in those circumstances and it should have to be done in a controlled way as much as possible. So to avoid that one, patient warming, covering the patient with blanket or room warming where the patient is admitted is better than blood warming.
So the place of whole blood transfusion for megaloblastic anemia.
Megaloblastic anemia, truly speaking, megaloblastic anemia, most of them they don't need transfusion. Nutrition-related anemias in general, they are either mild or moderate, and we don't usually get symptoms of anemia. Symptoms, they are usually asymptomatic and they can be managed by alternative methods other than transfusion. Otherwise, for megaloblastic anemia, if there is other causes, concomitant causes of anemia, if there is even combined, for example, with hemolytic kind of anemia, they may need transfusion. But there is no special about megaloblastic anemia as long as the anemia was severe and while we are treating the underlying cause, still we can transfuse if they are symptomatic. I did not come across anything special we need to consider in transfusing megaloblastic anemia. But what is very important is the anemias of such cause are usually does not need transfusion.
Okay. Is there any place for direct blood transfusion from donor to recipient in modern medicine?
Direct, we need to consider the ethics and the necessary arrangements and all the processes and the procedures. To me, I have not come across direct, connecting the donor direct with a patient. I have not come across, and it has a lot of risks. Otherwise, I have no knowledge about connecting directly from the donor to the recipient.
One last question, doctor. So, which blood product can be stored for the longest period?
The longest period is this fresh frozen plasma in deep refrigerator, which can be stored. The first one is the platelets, maximum of 5 days. The red cells, the whole blood, up to 35-45 days, they can be stored. Fresh frozen plasma can be stored for years.
Thank you very much, doctor. And on behalf of Blue Health Ethiopia and all our participants, we thank you for such an amazing presentation, as well as addressing all the questions at the end. And we hope we will be having more sessions like this with you in the future as well as with the members of the Ethiopian Society and of Hematology and Oncology. So, at last, if you have anything that you want to add, let me give you the stage one more time.
Thank you so much, Blue Health. Thank you so much, ESHO. And thank you so much, participants, for raising very important questions and attending. And what is very important is after this session, we expect you reflect back what we have talked as and against what is being practiced in your respective health facilities. Like consent is very important. Like in children, sometimes you see unnecessarily keeping children NPO during transfusion is unnecessary. And the following patient, transfusion during duty or during weekend has to be minimized. In the blood bank, we have serious shortage of blood, the blood components, the blood bank, and the other partners should work jointly to avail the required amount of blood for the nation and for the health facility. And for pediatrics, we don't have the blood bag. We don't have blood bag, which is small. We are wasting a lot of blood because we discard the remaining blood volume after transfusing a small amount of blood for neonates and the children. I will appeal to the blood bank and the Ministry of Health to avail pediatric blood bag so that we save blood. These are some of the things. And before transfusion, it's very good practice. This is what I encourage the service providers and in hematology and oncology to discuss hematology.
Thank you very much. It was an interesting presentation, and we hope we will meet in the future again. And good night.
Thank you so much for the presentation. Thank you. Good night.